The new innovative piece for this project is, while we do have clinical care, most of the clinical care is actually in institutions. It's in hospitals, it is in health units. The expectation is that the patients know about the care where it is provided and that they will be able to reach these health units. Unfortunately for us in Uganda, most of our patients don't know where the care is provided, which health units, but also the distance to the health units. There's also the idea of having continuity of care beyond the healthcare facility. As we know very much from the recent years, from integration of mental health into primary health care, but also strengthening the community component, moving people out of institutions and moving them, and having people with mental disorders also included within communities. There's therefore a need to strengthen the community component, because you can't say you provide the medications in the health unit and send them home without any support in the community. So what this one does is that it addresses that piece, moving beyond the healthcare units. So we are training community resource persons, so they will also be recognizing and they'll be referring patients. But we're also helping people within the people with mental disorders to form patient support groups. 10 to 15 patients with their 10 to 15 carers will form a group, and these will provide peer-to-peer support to each other. But another piece which I didn't talk about, which is a barrier to care, is that of livelihoods. Many people get better and they go home and nobody is willing to employ them, mainly because of stigma, but also because their skills may be limited by the disorder. So what we are also contributing is the livelihood component, which may prevent people with mental disorders and their households from getting impoverished, from falling beyond where they are in their level of poverty, because most of our people are poor and going even lower. So if you rule out the distance that they have to travel, because we are bringing services closer, and also if we provide some level of income for them to actually pay the little money they may need to go to this place which is close to them. And the third piece is the anti-stigma piece. So the communities are going to also be, we shall have anti-stigma activities to make the communities enabling. So healthcare workers, when a patient comes in, will be more receptive to treating them in a manner that is, like they would treat any other patient. So pulling these three pieces together and delivering them as a comprehensive package for us is the innovative piece. It may seem routine to others, but in sub-Saharan Africa, each of these pieces alone is maybe delivered by NGOs, or by one different NGO does stigma in one piece, another one does livelihood for another group of patients. We provide the healthcare delivery, but we provide it in health units. So this one now brings it all together into this comprehensive package.